Good evening, everyone. A very warm welcome to all of you joining us today for this webinar on Duchenne Muscular Dystrophy, Advances in Prevention, Diagnosis, and Next Generation Therapeutic Breakthroughs. I'm Dr. Monica Darji, General Manager for Scientific Marketing at Unipath Specialty Laboratories and Unigenome, and it is my privilege to open the session today. Just 2 days ago, the world came together to mark World Duchenne Muscular Dystrophy Day. And today, we carry that spirit forward to strengthen hope, share knowledge, and accelerate the journey towards better care and future therapies for every child and family touched by DMD. At Unigenome, the genomic division of Unipath, we are deeply committed to advancing the genetic science and making cutting-edge diagnosis more accessible. By bringing together global experts, thought leaders, our goal is to empower clinicians with the latest insights that can transform patient care and the outcomes. Before we begin, a quick note on the housekeeping. Everyone except for the speaker and moderator will be on mute during the entire session. We encourage you to ask questions by typing them in the Q&A box, and these will be catered to at the end of the session. The session is being recorded and the link will be shared with you afterwards. Now it's my privilege to introduce our moderator and speaker, Dr. Anup Rawool. Dr. Rawool is a highly accomplished senior consultant, clinical and cancer geneticist with an MBBS, MD in general medicine, and a DM in medical genetics. He also holds advanced qualification in healthcare management, including an MBA in hospital administration, PGD-GM, and PGD-HHM. He is the founder director of Sahaj Genetics Center and serves as consultant geneticist at Shayadri and Jupiter Hospitals, Pune. In addition, he is an esteemed advisor at Unigenome. We are honored to have him as moderator and speaker to lead this important discussion today. Over to you, Dr. Rawool. Thank you.
Thank you, ma'am. Thank you for the kind introduction. First of all, let me first introduce our esteemed panelist for today's event. So today we are hosting a webinar for Duchenne Muscular Dystrophy to create awareness for clinicians, patients, parent support group alike. So the theme that we have kept is testing and management, molecular therapies and beyond. And here the discussion with the expert panelist is going to focus on awareness that we can create. Lot of information is already available in the scientific domain. So how we can simplify it for the benefit of the patients and the families alike, and also for the general practitioners and pediatricians. That is the focus for today's webinar. So not taking much time, I would like first to introduce our esteemed panelist. On panel, first we have Dr. Vivek Mundada, sir. He is a renowned pediatric neurologist who's based in Dubai. He has over 20 years of experience in the field. He has practiced in UK, in India for quite some time, and he's now based in Dubai. He specializes in pediatric neurology, and he has been pioneer in introducing and supervising gene therapy for SMA and DMD patients in Dubai. So currently he has over 175 patients who are for SMA, and few are and more are getting enrolled for DMD. So he is also advisor at rehabilitation centers. He is actively participating in clinical research programs and improvising on clinical disease management guidelines with Dubai Health Authority for SMA and DMD. He is a renowned person in the field and a down-to-earth, humble person, and a dear senior colleague for me, whom I've commonly reach out to for any advices, particularly to pediatric neurology. Next in panel, we have Dr. Eshan Dabhade, who is a medical geneticist. He's done his MBBS, MD Peds, and then DNB in medical genetics from Gangaram Hospital, New Delhi. He is setting up his practice in Navi Mumbai now, and he is also associated with Unipath Labs, taking care of the reporting segment for the NGS. So before we roll on to the topic, I would like to share. Yeah. So a brief about a DMD. What is the status? So these are the learning objectives throughout the panel discussion that we aim. But the focus per se will be on diagnostic modalities and treatment options, treatment and management, for which we'll seek the opinion and expert advice from our esteemed panelist. So DMD, as we know, is a neuromuscular condition. Worldwide, the prevalence varies between 1 in 5,000 to 1 in 6,000 live male births. Now, this is a sex-linked disorder. DMD, the gene is hosted on chromosome X. So usually the females are the carriers, and male, when they get the abnormal dystrophin gene on the X chromosome, they manifest with the clinical symptoms. Basically, it is a neuromuscular condition where there is severe progressive muscle wasting, weakness that progresses, usually proximal motor weakness. The onset, there is a spectrum. DMD is more severe. Manifestation is at starts at 2 to 3 years, usually earlier than 5 years of age. And BMD, the onset is usually a bit late. The progression is also milder and slower. And there are other differentials clinically we need to look at. So since we have our expert panelists here, I would like to start the discussion with Vivek sir. Sir, for the benefit of the pediatricians, what would be the first clinical signs that we should be looking at, which should alert a pediatrician, or what should the parents be alerted when they should suspect DMD, sir?
So often see the motor symptoms are presenting symptoms. I think the presenting complaint, if you see the parent's perspective, they usually complain something called developmental impairment. And, for example, a child is nicely developing, you have a pool of dystrophin gene, dystrophin protein, sorry, and then as the muscles start getting in a dystrophied and start breaking down, usually children start having affection on their walking skill, for example. So typically they start walking on toe walking. You have got a beautiful picture there of a calf hypertrophy. That's very classical sign. And because of the proximal muscle weakness along the pelvic girdle, there's a classical sign which I'm sure all the pediatricians would know is called Gower sign, where the child has difficulty in standing up from the sitting position. And the lower limbs are usually more involved, and the proximal muscle weakness is a classical sign of this type of muscular dystrophy. And the other thing which I think the dystrophin protein is widely expressed in different ways, because we do see some children with learning difficulties or speech impairment, and those kind of difficulties should also be kept in mind. Now, having said that, with any kind of developmental impairment, there's an array of investigation that one would do, starting from metabolic investigation, lactate and amino acid. But I would strongly recommend keeping a creatine kinase as one of the investigations for any developmental impairment, because I've got cases who presented with no or least motor symptom, but presented as a learning difficulty or intellectual impairment or speech delay, and we got caught up with the high CK. I've got cases where pediatrician has done liver function for some different reason, and they were high. I mean, these are the early diagnoses, what we can think, and the world is moving towards a newborn screening. But, although majority of the patient present with the motor symptoms and the classical signs like Gauss signs and calf hypertrophy, toe walking, and, developmental regression or delay, but it is very important to understand that these children can present with other symptoms. So the bottom line is, if you can keep your creatine kinase in that fancy, the diagnostic tool along with all the metabolic, then I don't think that you'll miss any DMD case with that.
Yes, sir. Thank you. That was like, even for me, I'm surprised, like, just subtle learning disabilities and high CPK values. Maybe the CPK start rising much earlier before the clinical signs for actual muscular dystrophy sets in. So that's a
That's
real
right.
red alert. So how do you
Yeah.
see, sir, like genetic testing and like previously muscle biopsy used to be utilized a lot when it came
That's
to
right.
diagnostics. So
Yeah.
how do you see it fitting into the diagnostic pathway now currently? Is there any utility or
So,
muscle biopsy, or you will rely on genetic testing?
well, there is still a little kind of role of muscle biopsy, but I might, show a flow chart if you don't mind,
Yes,
and that might just give
I'll
you.
stop sharing my thing. You can start
Yeah.
sharing screen from your end.
So we do have something called standard of care, which we see in the Duchenne muscular dystrophy. I'm sure you can see my screen here, and this is the
Yes,
paper from last night, and the last version. So they are in three parts. How to care, how to diagnose, the multidisciplinary approach, and this chart, if you can see, I think I may not be able to magnify it, but if you see there is an unexplained increase in transaminase. I said that sometimes the pediatrician will do liver function for some reason, and they will have this raised AST and ALT. If there's a family history of DMD, and if you have a high creatine kinase, then the testing for CK comes first, because that's a very easily accessible and cheap test, even before the genetic test. For any kind of muscular, I'm not talking about the Duchenne muscular dystrophy. So imagine the muscle is breaking down. It's getting with a different architecture. As the muscle start breaking down, the creatine kinase will rise. So because the Duchenne muscular dystrophy is the most common muscular dystrophy, that's the first thing to keep in mind. I'm sure Dr. Eshan will throw light on why we cannot do NGS and why MLP and sort of thing.
yes,
But the first thing you do is the genetic testing. I'll leave that topic with him for deletion and duplication. And if you find the mutation, you have the diagnosis, like deletion and duplication, mostly deletion we see. But if there is no mutation, a very small proportion of the cases can still be diagnosed with genetic testing. We do the sequencing of the gene, and then if the mutation is found, you still have the DMD diagnosis. Now, a very less proportion of the cases, you have high clinical suspicion that this child is a DMD or there's a family, whatever it is, and you still are stuck. There is no mutation found despite doing MLPA or NGS. And these are the children who undergo muscle biopsy, because what you actually see is a dystrophin protein in the muscle biopsy. So, if that's absent, and we had a very small proportion of cases, you're right, because nowadays we're not doing muscle biopsy because we have, easily accessible tools, genetic tools. Previously, we used to look specifically for dystrophin, but now, after filtering these children, the muscle biopsy has a little role again for the confirmation if you have high clinical suspicion.
right. So that's like it's sort of last arrow in the arsenal to utilize when in doubt.
That's
Right.
right. Yeah.
So, Dr. Ishan, my question to you, like, can you just throw a bit of light on what is this DMD dystrophin gene? What are the various disease-causing variants? How are they relevant? And coming to what test, which platform, and when actually we should do the testing? Dr. Ishan, over to you.
Thank you, Dr. Anup, sir, and good evening, everyone. And thank you, Unipath, for giving me an opportunity to, be a part of this and spread awareness about DMD. So, in order to explain, whatever the molecular pathogenesis of DMD, let me just, share a slide depicting the DMD gene. I think that will be able to, we'll be able to understand. Just let me share my slide. Okay. Is it visible?
Yeah. Yes.
Okay. So the DMD gene, it is the biggest gene, largest gene of the body. Okay, and if we consider the size of DMD gene, it is 2300 kb, that is 2.3 MB. And an average size of a human gene is around 10 to 15 kb. So you can imagine that this gene is almost 200 times larger than the normal size, average size gene. Now, if we look at the DMD gene, this is a figure which is showing all the exons of the DMD gene. So there are total 79 exons in the DMD gene. Okay, and this the bar down is showing all the protein domains of the DMD gene which are encoded by the respective exons. Now, one more thing to note about the DMD gene is that you can see the exons are arranged in a particular pattern, and that pattern appears to be such that the end of each exon neatly fits with the start of the following exon. Okay, so this is what is known as the reading frame of the DMD gene. Okay, so I'm explaining to you all of this because it has implications in diagnostics as well as in therapeutics. So DMD has 79 exons, and basically what we have observed over studies is that the most common way that the DMD gene is mutated is because of deletions, which is result of which causes almost 65% of the cases of DMD. Now, even if we look at the deletions, there are two hotspots. Hotspot means the higher frequency of deletion occurring in a particular region of the gene. So one hotspot is around in exon 2 to 20, and another hotspot is from exon 45 to 55. So these are the main regions where the DMD gene gets deleted. Okay, so of course, if deletion is the most common mechanism of disease causation in DMD, we would obviously go forward to do a test which detects deletions. So the test of choice initially used to be something called as a multiplex PCR test, which was a Beck's and Chamberlain test. Now, this Beck's and Chamberlain test used to check for deletions in the hotspot regions. Okay, but nowadays this test has been replaced by MLP, multiplex probe ligation amplification test, and this has now been the standard of test. So this test checks for deletions as well as duplications in the DMD gene. Okay, now there is something called as reading frame hypothesis. Okay, so what is the reading frame hypothesis? This was a hypothesis first postulated in 1988, and it basically tells that if a particular exon or a group of exons are deleted in the DMD gene, okay, and if the preceding exon, the exon preceding the deletion, and the exon that is following the deletion, they don't fit together. Okay, so here we can see that how the exons get neatly fit together. But if, let's say, for example, exon 45 is deleted, okay, so we can see over here that exon 46 and exon 44 will not fit together after exon 45 is deleted. So this is known as a out of frame deletion. Okay. On the other hand, if let's say both 45 and 46 are deleted, so then we will see that exon 44 and 47, they come together and they fit together. Okay, so this is known as an in-frame deletion. The reason why this pathogenesis is important is because according to the reading frame hypothesis, out of frame deletions lead to a more severe phenotype, that is the Duchenne Muscular Dystrophy phenotype, where children become wheelchair bound with less than 13 years of age. Whereas in-frame deletions lead to a milder phenotype, which is known as the Becker's muscular dystrophy phenotype, in which there is a little later onset of muscular weakness. Okay, this knowledge of the deletions and in frame and out of frame is also important, because a lot of drugs have been designed in order to circumvent this problem of exon deletion, that we'll come to in a later slide. Okay, so firstly, I've told that the most common mechanism of DMD is because of deletion, okay, which occurs in almost 65 to 70%. Okay, DMD can also occur because of duplications of the DMD gene, which account for around 10 to 15% of the cases. Rest of the type, DMD can occur because of point mutations. Now, point mutations can be either a splice site mutation, it can be a nonsense mutation, and it can be a frame shift mutation. All of these will lead to loss of function of the DMD gene, which will ultimately lead to loss of production of the dystrophin protein, leading to DMD phenotype. Again, knowing the pathogenesis is very important, and knowing the molecular diagnosis is equally important. Firstly, because there are drugs, again, for nonsense mutation, we have got PTC skipping. So we have got other drugs.
I think we'll discuss.
Okay,
let
okay.
it go with the flow. Sorry, but that
Yes.
we'll discuss.
So
bit later.
basically, to summarize, DMD gene is caused by deletions, duplications, and point mutations. Deletions being the most common. Okay, and we do MLPA as the first line test. If MLPA comes out to be negative, then we go for the second line test, which is the NGS. In this case, whole exome sequencing will cover the entire DMD gene, the exonic regions of the DMD gene. And if it comes out to be negative, like Sir mentioned, that rare cases of DMD, they do come out negative even at NGS, then there can be other reasons, like there can be a deep intronic mutation which cannot be picked up by whole exome, or there can be a structural rearrangement where DMD gene is disrupted by an translocation event, which will not be picked up by whole exome sequencing.
Right. Thank you, Eshan. So, Vivek sir, from what Eshan discussed, I just wanted to know, since you discussed how often there have been cases like you have done MLPA, got negative, yes, gone negative, and in your recent experience, how often have you done muscle biopsies, or there have been differentials like LGMDA and FSHD, etc., those muscular dystrophy being diagnosed? So what is your experience, sir?
Yeah, I think if we talk about the DMD in last 5 years, I've just had one case which was diagnosed with biopsy. But otherwise, I mean, these times, I remember the days in my training, and now it's mostly picked up with the genetic test. It's becoming very, very rare. As I said, these are the tertiary center cases where you're really stuck, where you have the facility for biopsy and a good histopath, the neuropathologist. There we can do it. As I said, in last 5 years, just one case that was really challenging. But otherwise, again, the role of biopsy may be, the different in different muscular dystrophy. But if we just talk about the DMD, the genetic
any
test
surprising diagnosis, like you're suspecting Duchenne's, but has come out some other muscular dystrophy, myopathies?
Not kind of overlapping, I won't say that, but there have been clinical suspicion of proximal muscle weakness and limb girdle the dystrophy, and it turned out to be Duchenne. Again, the carriers you can get caught with.
Yes.
I remember in UK when I was there was a the female who was manifesting with like a Duchenne, and we get that very rarely, although we say that females don't usually present. But it's very important because there are separate guidelines what to and how to monitor the carriers. It's important because as they grow, you have to really monitor their heart. They can get affected, very subtly, but you don't want to miss them as well. And because of the expression of the gene in the various ways. I mean, if you see the proportion of the cases, so we discussed about the in frame and out of frame, but again, that always is not matching, because there are some mutation where you would predict that Becker's a milder phenotype, but they turned out to be a severe minority of population. And as opposed to there are some kind of, you think that they are Duchenne, but they are very milder. Because the gene, we know that it's the longest gene that we know so far in the human body. And there are a lot of permutation combinations. So that genotype phenotype correlation is very, very important when it comes to the clinical practice, what is involved. And that's where the standard of care is very, very important to manage them.
So, how important these testing modalities you think are for prognostication that you just discussed, but from therapy point of view, like 79 exons, hotspots we know, there are quite a few drugs that are available.
Yeah.
How you see that utility? What chunk of patients actually are put on therapy, and how many are like diagnosed with DMD, but unfortunately for those variants, presently there is no therapy as such, or maybe trials are going on. What is your experience?
I mean, this is a most interesting field, I think, because if you go to the clinical trial website alone, and I won't be surprised, you would see more than 200 trials going on in this field. And recently when I was attending MDA meeting, and you'll be amazed to see, just for example, exon skipping 51, there are different companies will be doing different trials and the different ways. So in summary, because we now know about the gene and the mutation, which Dr. Eshan has mentioned, if you want to categorize now, the whole focus is about whether you can replace the gene. This is something what we call gene therapy. But the problem is the length and the weight of the gene is so much that there is no vector to carry the whole gene, just like we do in SMA and other kind of therapies. So there is a lot of interest on, because you just showed about the important aspects of I'm not going to go in the promoters and all those things, but the important chunk of the gene which can give you the essential elements of the dystrophin protein. And that's where they call it as a microdystrophin or mini dystrophin. So the interest is whether you can chop down the dystrophin gene to important element, make it stable, and with all the essential element of stop codon in promoter, whatever, and then can you fit that into a virus as a vector and give this. And this is the gene therapy. We know there is one product available called Erivedis, and there are more trials going on with different types of microdystrophin. Pfizer unfortunately had to abandon the trial because of the side effect. The other is again the GAL-GT2, which is a compound which again encourages the overproduction of the protein. So again, there are trials with that GAL-GT2. There's something which you mentioned about the hotspot, like 45 to 55. There are a small proportion of cases, almost like 6%, which present as a duplication. Now for deletion, you can do the exon skipping, but there is an interest whether we can do multiple exon skipping. For example, if it's a big mutation, can you do like 2 sites instead of 1? And what about the duplication? Because there is a trial for let's say exon 2 duplication, and hopefully we might get that. And very lately, the whole interest of gene therapy is into like CRISPR technology, which is nothing but the editing. Can you edit the mutation, and then refeed? So I think the future is for that technology now, because there's a lot of interest in the CRISPR-Cas9 technology. And not to forget the loads of trial on exon skipping, because we saw, and he just pointed out of frame and in frame mutation. So from out of frame, if we can make somebody as an in frame mutation and give a small but functional protein to these patients, that's another approach to convert them into like a Baker phenotype. So exon skipping, we know there are 4 drugs mainly available. Recently, we got the exon 44 skipping, so hopefully it'll be in the market next year. Another exon skipping 51 will be there. And another one is like nonsense mutation read through. That's another approach that we can do. There is, forgetting about gene therapy, now you know that it's a multi-system disorder. It can affect your heart. It can cause a fibrosis. Just like SMA, we have seen the small molecule. There is an interest because, it's the expression of whatever the gene you are giving, whether it's going to go in the right places. Will it protect the heart? Will it protect the bone? Will it prevent the fibrosis? So there is an approach by giving a multiple different ways, apart from the gene therapy, like combating the fibrosis or reducing inflammation. Givinostat, for example, is there. We have been using steroid traditionally. So there are new generation steroid like Vamorolone is FDA approved. improving muscle growth and protection is there, restoring the cell energy, improving the heart function. So there are lots of interest in the therapeutic area to target in different areas. So the future is bright. As I said, there are a lot of trial, but at the moment we are working on microdystrophy and exon skipping like modalities.
Sir, are there any trials going on at your center or nearby that you're aware?
No, we are just involved in the clinical trials, but not in the pharmacy trial. It's because of the the stringent criteria for MOH, the Department of Health. So in the region, only Saudi has slightly lenient this thing. So there, Israel and Saudi, I would say, are closer to India, apart from they're in Japan and all. That Russia and China, like they have their own product and they do their own trials. But I'm just talking about the multinational trials. So unfortunately, not at my center. We do our own, kind of local trials only. Yeah.
Okay. So Dr. Eshan, we discussed about the in-frame, out-of-frame mutations that can be picked up on MLPA. So just like, is it possible that you have some SNV point mutations, okay, and still you could apply this exon skipping this drugs if that variant is lying somewhere in that particular exon. So I'm talking of utility of this therapies for SNVs. Is it possible?
So theoretically, sir, it is definitely possible, because if, let's say, there is a nonsense mutation in, let's say, exon 51, and if we skip that exon, and if we just allow that, but the problem is that then we'll have to look at the chart whether by skipping exon 51 in absence of deletion, whether we can bring something in frame or not. Otherwise, we by skipping exon, a particular exon, we will put it out of frame. So it will probably we'll have to do some permutation combination. So it is definitely theoretically possible, and it is an active area of research.
Yes, most of the times, like in MLPA, when we pick up deletions, particularly when it is a single exon deletion, we are always suspicious. Is it some SNV there because of which we are getting this single exon deletion?
Yes.
So that then needs to be ascertained, right?
Yes.
Because is it an exon deletion or SNV? The MLPA is throwing up. Yes.
Sometimes in MLP analysis, because of this single nucleotide variant, the primer doesn't get bound on the MLPA, and basically it doesn't amplify. So there is a false result of a deletion. Okay, but actually it is not a deletion of the point mutation of that. So that thing has to be kept in mind, especially whenever there is a deletion of a single exon. It should bring some suspicion in your mind that maybe it is a point mutation over there.
So Vivek sir and Eshan, question for both of you. In such situation where you get single exon deletions, how often do you recommend a confirmation or just cross-checking it with maybe NGS to confirm whether it is actual SNV or a single exon deletion?
Well, I often get guided by, geneticists on that. If I'm confused, I always pick up the phone and ask. But I would say, mostly.
One thing is that the lab does internal revalidation of that same assay. Okay, and by probably changing the primers or something, but basically they will rerun the sample just to confirm. I just recently had a case of exon 2 duplication, which was picked up in the first run, and then it was not picked up on the second run. So that is also possible. So then we ended up not reporting that, even though exon 2 duplication is the most common amongst the duplications in DMD.
Confirmation by alternate techniques.
Yeah, so we can do Bex and Chamberlain multiplex PCR. We can run
focused, for those,
for those, or we can run a RT PCR also, I think. So
right. So Vivek sir, like when you're talking about management of these individuals, we have spoken about so many therapies and all coming up. What is the current role of steroids per se, maybe in resource limited setting, particularly in India, or what are other alternative therapies that you think are more pertinent to the given scenario in India?
So I think even before the drugs, can I just mention, there are very good studies. So for example, I don't know if I can show the graph also, but anyway, so before 70s and after 70s, what has changed that we have given the longevity and, to the life of these children. They are living longer compared to what they used to before 70s. And that is not because of any drug. That is purely because of the multidisciplinary care that we have learned, to offer to these children. It is not about diagnosis and the palliative care, because now we know how the natural history is known. So there's a very nice study which shows how we have changed the standard of care by offering them the life of, and the kind of the care what we are offering. So the multidisciplinary approach, and if you see the document which I was showing on the PDF format, is in three parts. The first part focuses on the diagnosis part, and there's a neuromuscular part and physiotherapy. But there are three parts offering about pulmonology, the cardiology, and all. We do a 2-day preceptorship course along with Professor Mercury in Rome, and it is only about these things. So the drug, I always believe and tell that it's a part of the care. It doesn't replace all your multidisciplinary care. you know so if you're asking steroids, so it's something which is known to us since long time, and that hasn't taken away even in the era of gene therapy. Because if you see, vamorolone is a new form of steroid that we are offering to the children. So the target is different here. We're not kind of targeting the gene, but on the muscle level. We know that there is a cascade of muscle breakdown through the root of inflammation, and giving something non-inflammatory in the form of steroid is something we're just trying to prevent the muscle breakdown, or the inflammation rather. Again, the different drugs which are targeting to the muscle are in the pipeline, which I was mentioning. So yes, steroid is very, very cheap. I know deflazacort, there are a lot of argument, deflazacort, prednisolone, and so on. I'm not going to go in detail, but as simple as prednisolone or deflazacort, they're not very costly, but that's the part of standard of care that we know, even that we talk about. Of course, they come with some risk, but as long as you monitor them, as long as you see, as long as you know what to expect, yes, that can be given. But I think the most important part where I struggle when I transition the case, even after the gene therapy, is coordinating the care for the child. I've got cardiologists asking question, why do you want to start the drug when the child is 10, 11 and his cardiac function is good, his ejection fraction is good. So locally we have developed the guideline for pulmonology, for the sleep study, for the swallow assessment, for as simple as cataract and heart assessment. But that should be the thing, the care revolving around, because I know, having practiced in India, because the parent have to go through all the doors, knocking the doors,
Yes.
these doctors. So but if there is a pediatrician, and we're targeting the seminar to the pediatrician, I think all pediatricians should have seen the cases of DMD, and it should be a joint care. That's what I believe. Not just neurologists, not just anybody. So because it's not about treating the problem, it's the preventing of the problem is very, very important in these cases. We have seen children undergoing surgery for, let's say, contractures. But what if we can prevent those contractures with a good physiotherapy? The parents are not at fault, because we are, we're also sitting in that hub somewhere. So it should be someone who should be directing this, and there are loads of resources, believe me. I mean, we have got apps nowadays. We are in 2025, which we can ask the parents to download. And parental education is very, very important. The PPMD app, or, the standard of care. I know the people in India also, the Duchenne India, they're doing amazing work. I'm not saying it's not happening, but we should be reaching to the remote area. The education is important, not just therapies, the high-tech therapies, gene therapies, are costly, forget about that. But just the standard of care has, created a lot of difference in the lives of Duchenne muscular dystrophy. So yeah, steroid is a part of standard of care, and it should be given to all children still. Even if I give gene therapy, my children patients are on steroids. Yeah.
Yes, so it has its relevance, but it needs to be optimally utilized under proper supervision. So,
That's
and
absolutely.
eventually it has to be a multidisciplinary team which is taking care of various facets and aspects of the disease. One important point you brought out was prevention. So, Dr. Eshan, on preventive fronts, how do you see, like, for families, what precautions after the test is done for family or extended family, even from when you're doing genetic counseling, what would be the areas of focus for you as a medical geneticist? Dr. Eshan.
Thank you, Dr. Anup sir. So basically, whenever a child of DMD has come to, for evaluation at a geneticist, so geneticist looks at not only the child, but also the family, because the geneticist is not only concerned about the well-being of the child, but the geneticist is doubly concerned about transmission risk, okay, and the implications to extended family members. So if we look at DMD, the according to data, 1/3 of DMDs are because of de novo mutations, that is, they represent simplex cases, that there is no family history, and 2/3 of the DMD, the mother is a carrier. Okay, now mother can be carrier. If mother is a carrier, then there might be a history where one of the mother's brother had a similar phenotype and died during her childhood, around in teenage time. If and maybe because at that time testing was not available, so that it couldn't be completed whether this person really had DMD or not. But if that is what the pedigree shows, then probably we can assume that the mother is a carrier. Another simple way of checking whether mother is carrier is to do CPK test also in mother. If CPK is elevated, then we know it's carrier, because almost 50% of cases having DMD carriers have elevated CPK levels. Okay, so how does carrier status of the mother change the counseling with regards to recurrence risk? And it has a huge significance, because if it is a simplex case, then the recurrence risk is greatly reduced, although not completely eliminated. There is still a risk of germline mosaicism, so gonadal mosaicism. Whereas if mother is carrier, then the counseling is completely different. In that case, we would say that there is a 25% risk in each pregnancy of a child being affected with DMD. If we look at sex-based counseling, then there 50% chance that if child is boy, then the child might be having DMD. If child is girl, then there's 50% chance that she will be a carrier for DMD. Okay. In either case, confirmation of that carrier status can be done by doing MLPA in case of deletion if identified in the proband, or in case of the child having a point mutation, we can just do the Sanger for that particular point mutation and confirm the carrier status in the mother. Okay, and this implication has to be explained to the family that there are others also at risk. Maybe the mother has a
cascade screening. Yes.
Another mother may be having another sister, and she might not be married, or maybe she's married but not yet having a child. In that case, if we can prevent the mother as well as her family members from by giving the correct knowledge, we can prevent the transmission of DMD in the further this family.
I would like to share one case here. When I started my practice in Pune as a medical geneticist 2020, hardly been 2-3 months, one Muslim couple came. This lady, she had two brothers who had Duchenne Muscular Dystrophy and had expired. She had witnessed the entire course of events and the morbidity and the mortality, and she was like totally scared. And she knew like somehow throughout the course that it is X-linked. She might be the carrier, and she was afraid of having pregnancy. And there had been 12 years of marriage, right? A Muslim couple, 12 years of marriage, this history. And again, one of her maternal uncle also had a similar history and had expired. And there was constant pressure on her from her in-laws that her husband should go in for second marriage. So there was some, marital discourse that was going on. So, and she had undergone, consultations at various centers over past 12 years. At one center, they got her this multiplex PCR test done for DMD, the hotspot. That was negative, and she was counseled, you can continue with pregnancy, you need not worry. But somehow she was not scared. She was scared and not very comfortable what to do. So then when she consulted, took a detailed history, drew a pedigree, and then I realized like, okay, why her mother was not tested. There's something like obligate carrier, what you exactly said during your previous the explanation, Dr. Eshan. So mother, her one brother is affected, two sons are affected. She's an obligate carrier. She has to have a variant. No one thought of testing her. So I was in Sahyadri. We had just started MLPA testing. We got the mother to do the test, and we found exactly there were 5 exon deletion that the mother was carrying in the hotspot. Then we tested this lady, and she was negative. But look at the wait, 12 years of wait to just to give a verdict. And that was 2020. And in 2021 mid year, she delivered a healthy baby girl. So, so it's a huge. So awareness is important. We have those modalities at our disposal, but how we utilize it, yeah, that becomes very important. So Vivek sir, we talked about gene therapies and various new treatments and that are coming up. But most important factor when it comes to any patient or patient management about the availability and affordability, the cost. How do you see it? Has there been any deviation over the past few years that you've been practicing and going ahead and long term? How it will impact the management and overall outcomes?
I think it's a multifactorial aspect. That's the reason why we see patients from different countries with a different approach and so on. What is important, I always say, is not to forget the basics of multidisciplinary. So, for example, even if I give gene therapy, that doesn't take away the need for doing the DEXA scan or scoliosis monitoring or heart monitoring, because it's not a quick fix. I know parents come with the hope that if I give the gene therapy, everything is rosy, but that is not the solution. Purely because, we have lost a lot of tissues. I always say in the simple words, whatever dead is dead. You cannot revive. That is beyond the human capacity. What we are working is on different pool, and not to forget, in DMD like cases, we're not giving a fully functional gene. What we don't know, because you must understand that it's not the gene that is we are correcting. We are giving a separate piece which is utilizing the cellular mechanism to produce the protein, right? May it be SMA or any kind of ex vivo treatment. So when the cell divides, there is no assembly for that particular gene to divide. It doesn't kind of replicate. So we're going to treat a certain number of pool. We don't know the longevity of the gene therapy. It comes with a risk like immunogenicity for the vector. The vector is the virus here. It's going to break down as a capsid, and the capsid will create immunogenicity. So we know a lot of examples of immunogenicity and how does it affect. No doubt, yes, there are research trial. We know that dystrophin is like the EMBARK, the recent the publication had showed that even after 64 weeks, there was enough amount of dystrophin protein that they have seen, which is fantastic. But yes, the answer to your question, is it easily available? Many countries, no. Even if it is available, is it easily accessible? Again, many countries, no. So there are a lot of kind of the political issues, there are socioeconomic issues. There, for example, in UAE we have something called patient support program where the drug is slightly cheaper than the other country. But even when I say cheaper, it's not that cheap for a common man to afford. We get a lot of patients, those who may have a very good insurance international, those we have tried to cover that under insurance. And lastly, majority of the chunk of the patient which fly to our center is those who have raised the money to afford this treatment. Having said that, my approach, may it be SMA or DMD, is whatever you can get earlier in the course of the disease is the best thing. Like in SMA, some countries they offer Spinraza or Risdiplam, whatever you can get as a free or cheaper or whatever, and that is very, very important. And same applies now. We know steroids we are giving, but would you give Vamorolone when there is a deflazacort available and you are struggling a lot to raise that kind of money? You have to really weigh that possibility. Gene therapy, we see a great potential, but there are a lot of work to be done at the political level, at the national level, to make it accessible, to make it easily available. But I see the struggle for many parents. Yes, I have got some Indian patients, those we have treated, but the hardship they have gone through to raise the money has been something different, which is not right platform to discuss that. But yeah, it is a good thing. But I won't be, clinically, if you want to discuss about, I think I can see some question about the gene therapy.
Yes.
We'll discuss in brief what it is and all. But
Yes.
yeah, It's a different perspective, how you the ethical dilemmas and all. So let's not discuss that on this
Yes,
platform.
there are
I just
absolutely.
want to I just want to add on to what Sir was mentioning about the importance of multidisciplinary care. So since I have not had any experience with regards to DMD gene, but I have a little experience about SMA gene therapy, which was available in India, on a compassionate basis. And what I saw as part of my training was that even though we gave that gene therapy to the children, the improvement was very modest because there was lack of multidisciplinary care, and there was no proper physiotherapy, no their child was still getting some respiratory infections, and child refused to be put on some pegylated this percutaneous gastrostomy because of the aspirations. So the because of which I realized that gene therapy, even though it looks fancy, and it is like parents think that it is the one-stop solution, the actual crux of the matter is that in absence of multidisciplinary care, any kind of therapy will fail.
Absolutely, absolutely. So, like in HGBJ
Yeah.
Center, when I was doing BM, when this enrolling for this program started, 65 SMA, patients had reached out, and finally only 2 were selected based on the stringent criteria. So, when you are funneling patients into such programs and therapy after so much of stringent criteria, then definitely what Dr. Eshan, what you say, it becomes very important to have a proper multidisciplinary team in place. And as such, Dr. Vivek, where he is practicing, they do have a multidisciplinary team. What he mentioned, so he constantly interacts with his cardiologists, pulmonologists, they have physiotherapists, pediatricians, developmental, and so on. So it's a teamwork, right? So next, when it comes to one of the important aspect of prevention was, well, like prenatal diagnosis. That is one. Once you do either by CVS or amnio, but here it's like a, if at all the diagnosis is there in the fetus is positive or affected, we see the pathogenic variant, then the only option that remains is like a medical termination, what we practice in India. Otherwise, the other better option is to go in for IVF, and where we do the embryo biopsy and test on the embryos, either by pre-implantation genetic diagnosis, that is PGTM. But Dr. Ishan, I just want your inputs, like what all variants per se would be amenable to, because to PGTM in detection in embryo biopsy, because we see lots of deletions, duplications, some SNVs. PGTM, the technology per se inherently has some limitations to it, right? So if you could just give a brief on this, please.
Yeah. So basically, pre-implantation genetic testing is the modality for parents who don't want to take the burden of aborting a child during prenatal testing. So they would want to know the status before the implantation, and only those embryos with the normal chromosomal makeup and the absence of the whatever the genetic mutation will be selected for transfer into the uterus. Okay, the problem with pre-implantation genetic testing with regards to especially deletion duplications is that the lab should be equipped of doing such testing, and I don't think that many labs it is standardized over this to do testing for deletion duplication. For most of it, point mutations, they can do the Sanger or single variant analysis. For deletion duplication, the problem with embryo biopsy is that the sample is very less. We have to work on very less sample, and it has to be amplified. Okay, and even after amplification, whether the correct quantity of DNA is available for testing, that becomes a challenge. So
absolutely. So there is something known as pre-PGD workup that becomes relevant. So not in DMD, but I had experience of one patient who had polycystic kidney disease, ADPKD, PKD1 gene pathogenic variant that was exon 1 deletion. And we were able to offer them PGD. It was done, we combined it by doing a linkage analysis.
Mm.
So that's how the lab proceeded, and we were able to offer PGD, and then they had a healthy pregnancy. So that's
in linkage analysis also there are certain
Yes.
criteria that we need
yes. For DMD, it
samples
will be
across generations, affected, non-affected.
yeah. So luckily for that family, so that was one odd case in last 5 years, because all this criteria we were able to satisfy, identify affected, non-affected members, look at the linkage, and then we were able to offer. So
Yes.
again, that becomes a rarity, and having so that becomes a rarity and luxury at the same time, having all those criteria is being fulfilled. So I think we have some questions in the from the audience. So one is like, I'll what methods of therapy are safe when it comes to stem cell therapies for DMD? I think I'll channelize this question to both my expert panelists, Vivek sir and then Dr. Eshan. Vivek sir, are any stem cell therapies being tried in DMD, or what is your experience or opinion about
Not
it?
at the moment. As much as we are developing on the genetic part of the therapies, the research is on the new microdystrophins and the exon skipping both. So that's the only thing. Stem cell at the moment doesn't have any role in any kind of this DMD.
Ishan, you want to add anything on this?
Yeah, so basically, unfortunately, I've seen a lot of cases in news as well as in other in local doctors groups and all, that stem cell therapy has been offered by certain healthcare practitioners for DMD, and it is not scientifically proven, and
Right.
it is not scientifically plausible also. If you remove stem cells from the same patient who has the DMD mutation and you're going to reinfuse it, it is not going to help. Common sense tells us that it is not a help, because it is going to cause the same. If you are giving stem
Dr.
cells
Ishan,
from
Unless you're
another
going to
person, maybe but that is not yet tried, and that should not be tried except
but
until
not only that, I've got some patient asking me for autism also. There's a load of interest in stem cell autism. And then I show them that page, the statement by AOC, and
maybe we
on
can
their
have a
webpage, they
separate
have
webinar on autism and stem cell therapy. There's a lot of
but I don't know. I mean,
undue, yes,
how to consult them. Yeah. Yeah. So,
there is
yeah. Anyway, that's the
undue
separate subject. Yeah.
importance given stem. So definitely it's unscientific. There is no scientific evidence as of now for stem cell therapy being utilized or as a therapy for DMD as of now, right?
I'll just
Uh,
show something of
yes,
interest now that we are talking about what is going on in terms of research. There's a very nice website which the parents can download, Parent Project Muscular Dystrophy. And it's just that website I'm just showing. So if you see what's going on in terms of the research, so the restoring or replacing dystrophin, that's an area of interest. But if you see exon skipping, these are available, all these top 5 are available. Exon skipping 45, Amond is 45, Elevate is we talked about 51. There are 2 products for 53. Again, these are available. Iteluren again has driven a lot of controversy, but it's nearly there. Again, we talked about duplication 2, exon skipping. The 51 is another interest there. That's how they're developing. I won't go into the mechanism they're trying to do that. Again, the gene therapy through different vector, exon skipping through, again, AAV virus, it's in the pipeline. The preclinical work has already been done. Loads of Avidity recently released the press release earlier, I think in August only, that is going to be available soon. FDA has given a go ahead with that. Same with this, this thing. So gene therapy, the Pfizer has stopped its trial, but these are again showing the primary result. I was there for their phase 1 trial presentation. It looks promising. So loads of gene therapy and exon skipping in pipeline. I was talking about how to combat fibrosis. There are drugs which should be released soon in the phase 3. Reducing inflammation, we have vamorolone already. We have deflazacort already. There are more kind of work, especially on monoclonal antibodies that will be there. Regulating calcium balance for your bones, improving the muscle growth. We have Duvisat. It's available in Dubai also. We're offering that. Cell therapy, small molecule inhibitor, these are there. Improving the heart function is also there. Ifetroban, again, it's by the Cumberland, and enhancing bone. The Roche is doing that trial. certolizumab. So, you see different target and different trials going on. So stem cell has no role into this, definitely. We will see a good kind of a cocktail of medication that we might be able to offer. I can talk about gene therapy later, time permitting, because I can see some questions there, but yeah.
Yes. So I think that was quite insightful. It looks like the future looks really bright with all multimodality, research, therapies being improvised, therapies that are available, and again, more of interdisciplinary teams that are being set up at various apex centers to cater to a specific cohort of patients with specific diagnosis like DMD. So there is one more question, like Mr. Sunil is asking, what are the methods of therapies? By methods of therapies, I mean, is he asking like, do we give IV infusions or for the therapies, or is it a oral drug, or for what duration the patients need to be admitted, monitored when we are giving this therapies?
Yeah. So exon skipping are mostly weekly therapies, all IV at the moment, IV infusion, which we give for like 1 hour or so. And gene therapy is once, it's again IV therapy. Only SMA will be starting intrathecal from next year, but at the moment it's still IV. In DMD, it's one-time infusion given over like almost like 1 to 2 hours. And the oral ones, givinostat is oral. All the steroids are oral at the moment. It's having said that, I mean, only for the acute situation, the steroid which we give IV. But otherwise, apart from the gene therapy and exon skipping, these are the oral medication that we give.
So how often do you see hypothyroidism in patients with DMD?
Well, not that often. Hypothyroidism, mostly no, because in my clinical practice, there's always a checklist of the screening test that we usually do. There's an endocrinologist involved in the care. Apart from the bone health, we do check all these vitamin D and thyroid and the all these things. So I haven't come across any. I wouldn't say, at least since I'm in Dubai, I haven't come across any the hypothyroidism.
Okay, right. So I think, do we have any more questions in the Q&A box? So I think most of them we have already discussed: positives and negatives of gene therapy, methods of therapy, safety, and stem cell therapy. Right, right, right. So I think, yes, on the DMD, the testing front, the management, the therapies, what are the recent advances? Uh, I think we've covered most of it. And it's been really, really insightful, Vivek sir and Dr. Eshan interacting with you. So I think we'll have this recording available and we'll be hosting it on our official site as well. It was really enlightening for me also, being working in this field, but still there are a lot many facets. Uh, it always come and hits. Okay, I know this, but maybe I was not implementing it in my practice, or I know this fact, but maybe when I was counseling the patients, this is an important point which I will use it next time in my practice. So even for general pediatricians and practitioners who are with us for this webinar, I think it's really enlightening, and the discussion after this session, I think we'll be a bit more wiser. And yes, therapies, there are still some barriers, some challenges when it comes to accessibility, affordability, cost. Yes, but going ahead, it's all about teamwork, how we can tackle various issues on this. So with this, we come to the end of today's webinar. My heartfelt gratitude to. So you want to say something? Sorry, Vivek sir.
No, no, just a couple of things. I mean,
Yes, yes.
because
Please,
I
please,
know
please.
there are a lot of program going on. I'm coming to the AOCC, and I was just telling you in Delhi, we have a fantastic workshop on 16th on neuromuscular, all this exon skipping and all we're doing. But above all, because I get a lot of queries, I think my MVT coordinator is also in the audience at the moment. But I'm more than happy to answer anytime, any pediatrician. I'll ask Dr. Anup to share my email as well. So anytime, because it's a pleasure to help all our colleagues. That's fine.
So I think you are the guiding star for us when it comes to SMA and DMD. And I really appreciate whenever I have had any doubts or any questions. Sir has been always there, and even for today's webinar, I have reached out to him at just a short notice, and throughout his busy schedule, he has agreed, and at short notice, he's here with us, discussing things and answering all the queries. So my heartfelt gratitude to Vivek sir, and looking forward, I
Anup,
would
I
be
would like to
attending.
just intervene for a minute.
Yes, yes.
Before you mention the vote of thanks, I just
No,
wanted to.
I'm not ending the webinar. I'm just mentioning thanks to Dr. Vivek.
Of
And
course, of course.
done the ending this thing, I'll hand over the baton to you. Yes, ma'am.
Okay.
Please.
Yeah, but I would love you to continue. Just wanted to mention that in the audience where we have experienced clinicians joining us, we also have a parent and trustee of Parent Project Muscular Dystrophy Mumbai Group, Mr. Amrish Kapadia. As a devoted parent and passionate advocate, Mr. Kapadia has been playing a pivotal role in bringing global scientific collaborations, research initiatives, and patient support systems for to India. And his personal journey has inspired the establishment of a strong parent led movement that empowers families, spreads awareness, and works tirelessly towards better care and future therapies for DMD. So, Dr. Kapadia, if I would just unmute you, if I would request you to kindly share a few words with our audience about the impactful work of PMD and your vision for the community. I will just unmute you. Just give me 1 minute. Yeah. So you've been unmuted, Mr. Amrish Kapadia. Would love to hear from you.
Yeah, hello.
Yeah.
Yeah, thank you for giving me an opportunity to talk on this platform. It was very enriching listening to all the experts in the field, especially Dr. Vivek sir and Dr. Eshan and Dr. Anup as well. Uh, it really gives us the hope that, the future will be bright for DMD. I mean, when my son was diagnosed, he was just 18 months old, and now he's just completed his 18 years old. So it's been a very long journey for us from 18 months to 18 years. And we came across all the therapies, like I have seen gene therapy growing since then. I was in touch with Dr. Jerry Mendel uh, almost like 15, 17 years ago when gene therapy was still in the infant stage. And now looking at gene therapy coming into clinics, it's it, it it's really good. I mean, it's fine that it has come in the clinic as well, but the cost wise, obviously, it's still very expensive. And we tried our little bit in India to collaborate with Narayan Netralaya Foundation in Bangalore, where we collaborated with a scientist who had just come from US after his PhD, Dr. Arka Ghosh. He's a wonderful, very knowledgeable scientist in the field of gene therapy. I would say he's one of the assets that India has got in gene therapy. We also developed some microdystrophins with his help, and we also showed that there was efficacy in the mice models we imported from Jackson University. Unfortunately, we could not move forward into clinics because of the financial constraints. But nevertheless, we did that much work, and we hope that one day that will come in the clinics and will be competitive and affordable to many patients across India. We also, like as Dr. Vivek sir was talking about multidisciplinary care. So that is what we also made a guidelines, and I'll share it with Dr. Purvi Ben. It was just recently that we made a whole holistic guidelines, right from diagnostics to pulmonary care to bone health to endocrinology to cardiacs to pulmonary, and every aspect has been covered. And that I will share with Dr. Purviben, who's been very close with me. Uh, I have a few questions for Dr. Vivek sir, if he could answer. Hello.
Yeah, sure.
Yeah, sir, my query was regarding, as you said, that the dystrophin, microdystrophin was expressed over 64 weeks. So when it comes to Western blot, is it very standardized that, what percentage of dystrophin we should be looking at to make any therapeutic difference?
So good question. Again, this is from the research. Clinically, we don't do any muscle biopsy or check for that. Our approach, I mean, again, if you see the recent guideline, is mainly on the clinical parameters, the functional scoring that we decide the
Mm,
progress. So my, the comment was based on the EMBARK study that they have presented early this year. Um, Again, it'll be very interesting to answer your question to see the proportion of dystrophin and the clinical improvement or the functional kind of improvement. Do we have any correlation to that? That is something will be very interesting. But again, as I said, I may not be able to give that answer because our approach
okay.
clinically is very different than
Mm.
the research data.
Okay, and regarding exon skipping, like we also have clinical trials with exon 51 that have been going in India in few centers.
Yeah.
And in last 5 years, like what we hear from the clinicians who have been the PIs in this trial, they say that the dystrophin expression, the changes in the dystrophin expression is less than 1%. So
That's right.
again,
Yeah.
my question is the same, that how it will be correlated with the percentage of dystrophin versus therapeutic benefits. So is
Yeah.
1% or a less than 1% really going to make that much of a huge difference when it comes to functional improvements in the child?
It's not. Again, that is where, you see why EMA has turned down, some of the drugs based on
Yeah.
the, uh, you know, so this is an ongoing debate. So we don't have a perfect kind of remedy. I agree to that. It's like,
Mm,
in a simple term, something is better than nothing. That's what I would say. Whether that much amount of dystrophin is going to make a huge difference clinically depends on the baseline clinical characteristics and all. But I completely
mm,
agree. It's about the amount of money you would spend in exon skipping every week, the child going under trouble, and how much benefit you get. Even my clinical experience has been very varied, in terms of the amount of benefit you would see. Same like the gene therapy. So I only hope that the better time will come uh, where we can give better hopes. But at the moment, I completely agree, Mr. Amrish. Uh,
So just
and
one
regard,
thing to add regarding the gene expression when you talk of 1%, whether it makes a difference. I would like to draw a parallel here, not exactly DMD, but when we talk of inborn error of metabolisms, we look at enzyme levels, right? So enzyme levels less than 1%, clinical manifestations is there. Even like 2 to 5%, there is gray zone. That much enzyme activity is sufficient, and patients usually don't manifest when it comes to IMs. So
yeah.
1% expression. So maybe we need to do some functional studies, or maybe data is already there. We are not aware that we need to dig into. So
So
bit
yeah,
of even
again,
one.
so the normal dystrophin expression is like around maybe more than 50% in normal healthy
right.
individuals. So when we
Yeah.
are talking of normal is 50% versus less than 1%, and that also not improving after 5 years,
Yeah.
6 years.
So I
So
think,
how far we
see,
should
there
have
are.
hopes from such things?
We should have, yeah. If you see the exon skipping studies, the mainly rational, so the BMD and DMD are the result of out
Mm,
of frame and in frame mutation. But it's as I was saying, there are some phenotype which will not correlate. Some of the deletion resulting from exon skipping may not lead to improved phenotype. That's the reason.
mm,
And again, that approach may lead to a truncated transcript, that
mm,
may not achieve the required functionality to improve the symptom due to that exclusion of indispensable regions, or what Dr. Ishan was also showing, or the impaired protein folding. And the suboptimal efficacy of these therapies in the patient is largely attributed to the challenges associated with the poor uptake into the
ah,
cell, and even the endosomal entrapment. So although
mm.
it looks nice theoretically, but the lots going on at the cellular level, I would say, and that is the reason we don't get that kind of result which we would expect. So it looks nice, if you see the gene diagram, okay, we'll skip that and get that in frame, but it's not exactly what happens at the
More
cellular level.
sophisticated.
then what it
One last
appears on
question is
screen.
about the givinostat, which is a HDAC inhibitor, the histone
Mm,
deacetylase inhibitor. Now, when we are talking of histone deacetylase inhibitors, that means we are unwinding the DNA and exposing the genes for transcription and translation. So, I mean, when we are talking of HDAC inhibitor like givinostat, which is a pan HDAC inhibitor, so will that
yeah.
not expose the genes continuously, which otherwise should also get silent? So will that not result in any kind of unwanted side effects in the long term?
Well, again, what we have is only the research data from that. There's nothing, if I remember correctly, documented in those terms. Theoretically, yes, that's a valid question, what you have raised, but at least we don't have any such insight from the research.
Because when I was
But
reading
yes,
about its side effects, I mean, there was a lot
yeah,
of like 30% face diarrhea or
that's right.
thrombocytopenia, and all in double
Yeah.
digits. Like even the cardiac sinuses and erythema was there. So,
Mm,
I mean, how far are we risking these drugs? Or because our children are anyways very vulnerable when it comes to cardiac health, their cardiac functions are compromised. So, if
mm,
somebody has this kind of side effect in the cardiac sinus, in the or maybe tachycardia or in the electrocardiogram, is that something
yeah.
which can be reversible after withdrawing the drug, or we need to add some more medications like
No, so if you
metoprolol
see at
or
the
something
moment,
to?
Not really. At the moment, that the focus is just on adjusting the dose. If you see, clinically,
Mm,
that's what the guidelines we have. Nothing as such. But I agree, theoretically, there are also talk of tumor cell effects, let's say, so we can go on and on because of that DNA damage and repair, environmental exposure, the cancer therapy. Yes, we agreed that, but there is no kind of guidelines given to us at the clinical practice level. At the moment, we're just guided with the side effect by monitoring the bloods and the clinical side effect and
mm.
then adjusting the dose. That is the only
I
thing in
just want
hand.
to make one
It's
And
an
how would
point
interesting
you
area
that
to me.
this.
how would you weigh the? I mean, I'm just talking about repurposing drugs because this is something which
Mm,
the countries like the low income group companies like India can afford. I mean, if there is
yeah.
like canakinumab, I was reading in your the PPMD page that you saw that you
Mm,
cited here, Iliaris. The canakinumab is
yeah.
anyways used in rheumatoid arthritis, and
True.
it's safe in children. It's a monoclonal antibody directed to IL-1B inhibition.
Mm, mm,
So, I mean, how would you hypothesize that? I mean, of course, it has to undergo a clinical trial, but looking at
yeah.
the mechanism of action and its a long use in the pediatric patients, is that something which we can equate with the outcome with the vamorolone or other drugs? Because this being
So
more
again,
specific to the pro-inflammatory interleukins.
that's right. So again, that's another interesting area. Whenever I meet, Montoni or Mercury, that's the point of discussion, that we believe that such combination may work in future. I was also talking about different targets and how with different modalities. So possibly yes, the answer to your question that we may be able to use that. Of course, we need robust kind of clinical trials because once the drug is in the market, then we are gonna go ahead and combining them just like we do in SMA nowadays to see that. But yes, theoretically, yes, the answer to your
Like
question. But
tetralizumab is
clinically,
also
I
there.
don't
I
have the
saw in
answer.
trial, which is IL-6 receptor inhibitor.
Receptor
So,
inhibitor, yes, that's right.
so
That's
if
right.
we
So
are
let's see.
targeting those specific pro-inflammatory cytokines, then maybe we can give up the steroids or taper the dose of steroids, which are
Absolutely.
have a lot of side effects.
It is not very safe. Yeah, absolutely. Agree to that. Yeah.
Yeah. Thank you so much for giving me opportunity to talk and ask these questions, doubts
Thank you.
to Dr. Vivek sir.
Thank you, Mr.
Thank you,
Kapadia.
Dr. Amrish. I think the points on questions, they were really enlightening. Like those perspective, we hardly discuss. More of the research aspect it is. As a clinician, yes, we should, how the therapies work. Once we understand what exactly we are going to target and how we are going to benefit, and once we analyze this process critically, then comes the utility and applied aspect. Yes. Thanks for those questions, Dr. Amrish.
I'm not a doctor. I'm just a parent. I don't
Oh,
have any medical degree as
but
such.
I appreciate the acumen and the knowledge that you have acquired. It is at par with any of us here. Yes. So Dr. Monica.
Yeah. So I think this one last question from Mr. Sunil Kumar. In some cases of DMD, we see associated other neuro problems. So what is the reason?
Well, I think I answered that question. So
Okay.
it's
Okay.
about, yeah, it's not a straightforward kind of gene. It's just like, um, I don't know what he mean by that, but I don't want to go in detail because of the time and because
Yes.
that's the interesting
So
area. We have
I'll
seen
I'll
in
answer it
SMA,
in
we have
short.
seen
Yeah, I'll answer it in
yeah,
short on Vivek's behalf. So whenever a gene is expressed, it's not just the muscle.
yeah.
It is expressed everywhere, and it has multiple interactions with other protein products as well. It's not as simple as it looks, and that is the reason once you have a pathogenic variant in that gene, wherever it's functioning on or impact on any mechanism pathway in various organs is going to manifest. That is the reason we see for any genetic disorder, there is some impact on this or that organ system. It is rarely that you get a pure genetic disorder which is affecting only one organ system, and that too happens when that gene is particularly or isolatedly expressed in that particular organ. So I think that explains a part of what he has asked. Yeah.
Yeah. Thank you very much. So with
So
this,
before Dr. Monica tells, let me first express my sincere gratitude to Dr. Vivek sir for his time. It's been very late. He's been working late, and Dr. Eshan was busy setting up his clinic, and I stole his time for today. So sincere, heartfelt thanks, and uh, looking forward to meet you guys in person. Yeah, Dr. Monica, please.
thank you. So on behalf of Unipath and Unigenome, it's my privilege to extend a heartfelt word of thanks to all of you who has actually made today's session extremely enlightening. First and foremost, I would like to thank our speakers, Dr. Anup, for setting the stage with his deep insights on clinical genetics and moderating the session so wonderfully. Dr. Vivek Mundada for his global perspective and expertise on SMA and DMD therapies, especially the insights that he's shared about the DMD therapies. Dr. Eshan Dabhade for sharing his valuable clinical and genomic perspectives on this disorder. Um, so your talks have not only expanded our scientific understanding, but also has given hope for better patient outcomes. A special thanks to all our attendees, the clinicians, parents, and healthcare professionals for joining us in this evening. Your engagement and curiosity has truly made this academic discussion more meaningful. With this, we conclude today's program. Let us carry forward the knowledge gained and continue working towards advancing patient care in rare diseases like DMD. We would love to meet Dr. Vivek Mundada in person in future and do more such sessions with him. Thank you once again, all of you, and wishing you all a wonderful evening ahead. Thank you.
Thank you. Thank you. Good evening.
Thank you. Thank you.
Good night.
Thank you.